Thank you very much. The presentation of Marley's made my mind much easier. I have a disclosure to make. I do 30,000 intermittent dialysis treatment per year as being a nephrologist. And I do probably 2,000 days of continuous renal replacement therapy. So I'm using both therapies, and I think that as the media mogul Elliot Carver in the 007 movie Tomorrow Never Dies tells James Bond, it's not a matter of who, what, when, how. The problem, the real question is why. Why should you use a specific therapy? Well, severity of illness changes very fast in critically ill patients, and we have other organs involved. So our management requires attention to different aspects, not just the kidney. And extracorporeal therapies often have different indications rather than simply renal replacement therapy. And we have different modalities available. You have seen this slide before, and Marlis has clearly shown that there is a continuum between continuous and intermittent renal replacement therapy, moving towards in between some kind of hybrid therapies that are prolonged hemodialysis treatments, although intermittent. And this depends on several issues, including the hemodynamic state of the patient, the risk of infection in one side, and the need for fast removal of solute on the other side, or the speed of fluid removal. So we have today analyzed this from the idea that when a patient is admitted to the ICU, we need to analyze the patient, monitoring for AKI, and making a personalized evaluation of the patient demand capacity that Marlis has presented. Once you choose to move for a renal replacement therapy, I think that you have to identify the targets. So volume, solute removal, electrolyte, acid base, others, and then you choose the modality, which also depends on how you actuate the modality with vascular access, machine filter, anticoagulation, type of dialysate, and dose. Then you choose the therapy setting, and then finally you deliver the therapy, but collecting the data and being ready to restart the evaluation both of the targets or the selection of the modality. In a recent study we published in Critical Care, we have analyzed more than 1,500 sessions, and as you can see in critical care, I think that almost 2/3 of the therapies were continuous, while different forms of intermittent therapies were provided in 1/3 of the sessions. It has been clearly known and discussed what are the advantages of an intermittent approach, although we know also severe limitation, including the intolerance and fluid restriction required and the limited efficiency due to double pool kinetics. On the other hand, we know that we have advantages and limitations imposed by continuous renal replacement therapy, such as, for example, the continuous anticoagulation and exposure to the extracorporeal therapy. However, the excellent clinical tolerance is now well known as one of the most important advantages. Now, when you look for the literature and try to compare continuous versus intermittent, you find no difference. And you know why? Because these studies were horribly designed. If you look at the exclusion criteria in these studies, you will find that in order to randomize patients to continuous and intermittent, you had to exclude those patients who could not tolerate intermittent. So how can you compare two therapies like this? So there is no comparison. These are two therapies that are not one against the others. These are two therapies that you can use dependently on the need and the specific indications. So please, stop telling me about this no difference, because I think there is a difference, but not in the sense of a randomized trial comparing the two therapies. Now, I'm telling you why you should use different therapies. Many years ago, we found that the hemodynamic instability, the chance to see this episode, is increasing dramatically when you increase the rate of fluid removal in the patient. Now, if you look at the patient on CVVH, the chance of hemodynamic instability is very low because there is a very low speed of net fluid removal. On the other hand, the chance is very high in intermittent therapy because you have to remove often 3 liters in 3 hours. But again, if you need to treat a patient which is in an acute pulmonary edema, you may want to have a rapid fluid removal. Then subsequently, you want to have a stabilized hemodynamics with the fluid balance maintained over time. So again, these are different therapies whose characteristics are different and may require to be applied in different conditions. Now, there is a reason why we have this hemodynamic instability when we use rapid fluid removal in, for example, daily intermittent hemodialysis, because blood volume variation, body weight, and body weight variation is quite fast, inducing some level of hemodynamic instability. This is less evident when you try to use a prolonged session like 8 hours, which is a good compromise between continuous and intermittent, while you don't see most of the time blood volume variation in continuous therapies. Again, these are patients that if they are critically ill, they may require continuous therapies. But if they are stable patients, well, as you know, we do 30,000 treatments per year of intermittent therapy. Now, there are 2 reasons why you can actually have hemodynamic instability due to blood volume variation, and we in nephrology use blood volume measurement together with bioimpedance measurement to have an idea of the whole amount of fluid in the body and the relative amount of fluid inside the circulation. In this case, for example, when you have hypotension, this is due because you have a sudden drop in blood volume, although the patient is overhydrated, showing that you are removing too fast. At this point, you stop, you slow down, and the patient becomes stable again. Patient is still overhydrated. You can do a stable removal of fluid until a point in which you suddenly get a change in the slope of blood volume variation, and this is because the patient has reached dry weight or even beyond that point. At that point, instability is not due to too fast removal, is due to fact that you are removing too much. So you have to take care of the overall amount of fluid and the speed at which you remove fluid. Bicarbonate levels and acid-base correction. This is a typical effect of post-dialytic alkalemia in intermittent therapies, which is blunted in, let's say, daily extended dialysis, and which is quite stable in continuous therapies. Once again, it depends on your need for a fast correction or for a steady maintenance of correction. We have seen that in patients treated with intermittent therapies versus therapies that are done continuously, there is a change in brain density due to water shifts between intracellular and extracellular compartment in the brain. So definitely this may not be so important in a stable patient, but it may become crucial in a patient with the brain tumor or with the trauma. So again, continuous therapy and intermittent therapy may require application in different type of patients. And here you can see what we have defined as a subclinical event, which is the change in brain density in the in the gray and white matter that you don't see in continuous therapy. It's a very subclinical event, but it causes what we call brain gymnastics, like a sponge, and in a patient under critical conditions, this may have an important solute removal. I think that young fellows do not pay enough attention to the fact that extracorporeal clearance is just one element in the equation of solute removal. You are removing mostly for the vascular space, but if you don't have intravascular refilling from the interstitium and the intracellular content, basically you end up removing only solutes from the blood compartment. Now, we have different options in terms of techniques: ultrafiltration, hemofiltration, hemodialysis, hemodiafiltration, and we have different frequencies: isolated, intermittent, daily, continuous. Let me explain you why, for example, convection and diffusion or convection and ultrafiltration may be different. This is a patient that required fluid removal. So you remove by ultrafiltration 2 liters with practically a concentration of sodium of 140, so you remove 280 millimoles of sodium. At the end, you remove 2 kilos and 280 millimoles. In the other patient, you remove 10 liters using hemofiltration with sodium 140, and you replace with 8 liters with sodium 130. You still remove 2 kilos, but you have removed 360 millimoles. You cannot do this with any other tool, not with diuretics, the dissociation between sodium and water removal. The other thing is that in intermittent hemodialysis, sometimes ultrafiltration has a tonicity in the ultrafiltrate, which is higher compared to the one of plasma water because of the additional mechanism of diffusion. So when you end up, after dialysis, you end up with a very hypotonic plasma water, which leads to intracellular fluid shifts. This is not seen in hemofiltration and in continuous treatment. So you have to take care of this aspect. And in fact, the final result is that intermittent therapy is very fast reducing, for example, BUN, little shorter, little longer time lead to same type of reduction, but in a different slope. And finally, this is the curve for continuous therapy. But as you can see here, you have a post-dialytic rebound after a very fast therapy that leads to less efficiency and indeed probably remove less solutes because you have a very high clearance applied to a lower concentration in blood. And this is what is typically, kinetically speaking, the profiles in intermittent, prolonged, and continuous therapies for a given solute. Now, the important aspect is that in many studies, it has been shown that there is a tendency to a better recovery from dialysis dependence if you use continuous rather than intermittent therapy. And probably this is due to the fact that in intermittent therapies, in the critically ill patient, you have higher incidence of hypotension. And this is the renal replacement therapy dependency on day 90, comparing, for example, the renal with the ATN trial. The ATN trial, the American trial, had a much higher component of intermittent therapies compared to the renal trial in Australia. So, what I'm trying to tell you is, when they ask me, do you prefer continuous or intermittent? My answer is, In my hospital, if the patient is sick enough to be in the ICU, he does continuous therapy. If he's not sick enough to be in the ICU, most of the time he does intermittent therapy. So the two treatments are not one against the other, and you cannot use old studies to compare this treatment. Whatever treatment you use, Marlis is right. You have to have a quality control on what you perform. You have to be flexible. Try to prescribe the right therapy for the right patient and be ready to cross from one therapy to another depending on patient needs, making sure you're not under-dialyzing the patient and possibly individualizing prescription. If you want to hear more, please come to Vicenza next year, and we will be happy to get you there. Thank you.
Thank you very much for this very nice talk. Is there any question in the audience? Maybe on intermittent versus continue? Is somebody use intermittent renal replacement therapy? Okay. I have a question on the hybrid machines. Do you have any data, epidemiological data, on the use of SLED, PIRT, hybrid machine in the world? Is it usually used, the hybrid machine, or it's really rare?
To which machine are you referring to?
SLED.
SLED is a treatment,
yes.
is not a machine.
The treatment.
Okay. We use this. When we have a patient that is moving out of the ICU, where by definition we use continuous therapies, we immediately have the perception of what is his tolerance to fluid removal, his demand for solute removal, and we have immediately the perception whether we should prescribe a therapy that should be prolonged during the day, depending on the tolerance to fluid removal. It also depends on the need for fluid infusion of this patient. So fluid balance is the main target, and urea kinetics is the second target. I think that too often, especially young fellows and especially Americans, tend to categorize things without knowing the mechanism that is behind. I think that precision medicine is about knowing what patient requires, what patient needs in terms of fluid balance and solute removal, and then you prescribe the right therapy. I would like to also tell that there is a false belief that the blood flow is affecting hemodynamics of the patient. Blood flow is not affecting the hemodynamic of the patient. What affects the hemodynamic of the patient is the net ultrafiltration.
Thank you very much. I think, is there any question? One question?
Claudio, I'm sure many of your patients are also treated by intermittent hemodialysis, or not?
Excuse me?
Many of your patients are also treated by intermittent hemodialysis.
When they are outside the ICU.
Only
not
outside,
in the ICU.
Not in the ICU.
In the ICU, we have a small % of patients that are actually doing either nightly or daily, so 12 hours day or night shift, because they may require to be free from the extracorporeal circulation for different purposes. And in that case, we make sure that we cope those 12 hours, giving the right amount of dose and the perfect balance to keep the patient. But there's no question that if you don't dialyze a patient for 12 hours, in that time, he is progressively gaining fluid. And this should be carefully monitored for heart function and other things.
Thank you very much. We have to keep the session in time. Thank you.